Good evening, everyone. Thanks very much for tuning in to tonight's talk. My name's David Wechsler. I'm a glaucoma specialist and an ophthalmologist working here in Sydney at the Burwood Eye Clinic. I'm coming to you from the land of the Wongal clan of the Eora Nation. I'd like to pay my respects to elders past, present and emerging. We're going to talk about how to prepare for glaucoma laser and glaucoma surgical procedures. I'm on one of the committees of Glaucoma Australia, and here at Glaucoma Australia, we often get inquiries about this from patients. So it's a great opportunity for me to present some of this information. This information is of a very general nature, but I hope it'll be helpful. And we're going to have plenty of time for questions and answers. So send them in on the chat, and I'll be happy to deal with your questions. So under two different things. The glaucoma laser happens in the clinic and it's a bit like something that might happen at one of your appointments, whereas glaucoma surgery actually happens in hospital in the operating theatre. So I'm going to go through these separately. The laser procedures, what we're talking about, the most commonly performed laser procedure for glaucoma now is what we term SLT. The full name is selective laser trabeculoplasty. And this is treating areas of the drainage angle with laser applications like this. And another laser that's commonly done is laser iridotomy. We also call it a YAG PI because we use the YAG laser to perform it. And that's putting a little hole in the iris. And that's used to treat certain types of angle closure, glaucoma. Those are the two main lasers that we do in the clinic. There are other lasers that we do that are less common, and I'm not going to talk in detail about them tonight because they're fairly specialized, but there's a cyclodiode or micropulse laser, and that's actually performed in hospital, so it's a little bit like having a surgical procedure. And I also just want to make the point that there are a number of other lasers that we do in ophthalmology that have got nothing to do with glaucoma. There's laser as part of cataract surgery or after cataract surgery. There's retinal laser. And these are all different, again, for the laser refractive surgery, which is the laser so that you don't have to wear glasses. So just bear in mind that the laser is a tool and there are different types of laser that we use in different settings. So what I'm going to talk about tonight is the ones that we use in glaucoma. And when it comes to surgical procedures, these can also be grouped into different categories. The main glaucoma surgical procedure that's been around for at least 30 years, more, closer to 50 years, in fact, is trabeculectomy. And there are other external filtering surgeries. So there's newer devices coming through. One's called the Zen, one's called the PreserFlow. These things have in common the fact that we're draining fluid from inside the eye into the conjunctival space around the eye. So we form a bleb under the eyelid. So the fluid drains from inside the eye to that space there, and that lowers the pressure. So in the case of trabeculectomy, which as I said has been around for a long time, we're making a little hole in the eye to drain fluid. Some of the newer devices, we're putting in little devices to drain the fluid, but the goal is the same thing. So that's one category of glaucoma surgeries. The next category is the tube shunt surgery, which is actually putting a larger device. It's a tube that's attached to a plate that goes on the outside of the eye, and then the tube is inserted into the eye just like this. And there are, again, different devices with different names. I've listed some of them there, but the principle is the same. Then the third category of glaucoma surgery is angle surgery, where we're dealing in the drainage angle where the fluid drains out of the eye. And this includes certain devices to help drain fluid within the natural pathways of the eye. There's one called the eye stent, which I've shown here. There's other devices that do similar things. And this comes under the banner of the so-called micro-invasive glaucoma surgery. And it's sometimes combined with cataract surgery. So it generally not as involved as an external drainage procedure, but it still comes under the umbrella of glaucoma surgery, and it's sometimes done at the same time as cataract. Turning to laser first, this is performed in the office, so there's no need to fast or anything like that, and it's more like just an appointment, and it can even happen at the same time as your appointment. You may be given a separate appointment, depending on how your specialist wants to do it. You may turn up to an appointment one day and the discussion will be made, and then the decision will be made to have the laser. So even though it's just something that's done in the office as part of your appointment, you'll still have to sign a consent form as for a surgical procedure. It's still an intervention. And it's not just the signing of the form that's important. It just is an opportunity for you to discuss with your treating surgeon what the laser is, what's the risks, what's the benefits, and you'll be given an opportunity to ask questions about it. And the signing of the consent form basically acknowledges that you consent to the treatment and that you understand what's involved. In addition to consenting to the actual procedure itself, there's also the informed financial consent, which may be a separate document where it should be outlined to you what the costs are involved with your treatment. So when you have the lasers in the office, drops will be given beforehand. These lasers are performed on the slit lamp, which is the instrument that you'd be examined on, that you'd be used to. There'd be an anesthetic eye drop, but it's just administered as a drop. And then usually there's a lens applied to the eye. I've shown pictures of some of the different lenses we use there. It's usually a fairly quick procedure. And so sometimes it only takes a few minutes, but usually we get you to stay in the clinic afterwards so you can be checked afterwards to check the pressure and just check how the eye looks after the procedure. So you may be there for a little bit of time afterwards. Depending on what laser you have, there may be extra eye drops that you'll be required to use after that. And you might get a script for some new drops. You'll be instructed in what drops to use, whether to continue your regular drops, whether to use extra drops as well. And you'd then be given a follow-up appointment. Now, glaucoma surgery is a little bit more complicated. As I said before, it's going to be in a hospital. It won't be done in the ophthalmologist consulting room. So there's admission paperwork. Again, there'll be a consent form, and that'll be a hospital consent form. It'll be an opportunity for you to discuss with the surgeon beforehand any questions you might have and just be made aware of the purpose of the surgery, the risks and the benefits. There'll also be a separate IFC, or informed financial consent. And again, this can be quite complicated as it's a surgical procedure and there's a few other people involved, not just the main doctor looking after you. There will be some form of anesthetic, which will either be local or general. And when we say local, what that means is that there's an anaesthetist there who actually injects local anesthetic around the eye to numb the eye, but you'll be awake during the surgery, and there may be sedation given at the same time. If people are particularly anxious or claustrophobic, or they don't feel that they're up to having it done under local with sedation, then they may have a full general anesthetic. But either way, an anaesthetist is involved, which is a doctor that specializes in giving anesthetics, like for all surgical procedures and not just eyes. And you will have to fast for the procedure. You'll need someone to bring you to the hospital and take you home. You're not allowed to drive yourself, and you're not allowed to leave unattended. So you have to have someone with you. And it's important to discuss your medications before the operation. The anaesthetist will want to know, but your ophthalmologist will want to know as well. In particular, blood thinners are important. Some ophthalmologists like to stop blood thinners for some of these glaucoma procedures, some of the ones that I mentioned. And whether or not it's safe to stop it depends on your general medical condition and the reason that you're on the blood thinners in the first place. So that has to be discussed ahead of time. It's an important consideration. This also includes things like fish oil and supplements, because sometimes they can increase the bleeding tendency. And so as part of your admission paperwork, you'd have to fill out all your medical history and all your medications, including vitamins and supplements. For people who have got diabetes and are on diabetic medications, that also needs to be discussed ahead of time, as when you're fasting, you may need to alter what medications you take. Now, as a general rule, and this applies for the laser as well, you should use your glaucoma medications on the day of surgery as well, unless otherwise told. Then once you have the surgery, the eye is usually padded overnight. There'll be a post-op visit the next day. You'll usually be seen the next day, which we call the day one post-op visit. After that, the surgeon will examine you and give you further instructions, and you can expect a series of follow-up appointments. There will be a period of aftercare, and for some of these glaucoma operations, there are post-op manipulations required. And so you'll be given a series of appointments at which this is undertaken. You will need to discuss with your surgeon ahead of time how much time you'll need to take off work, when it's safe to resume driving, and what restrictions there are on your physical activity. For some of these procedures, we tell people no bending, no lifting. For operations like trabeculectomy or any operation where we're talking about draining fluid out of the eye, it's a good rule of thumb to keep the head above the level of the heart for the first 2 weeks or so, depending on what the pressure is. But there's usually fairly specific instructions given about that. But just be aware that that could be an issue. And now this, contrasting that with the laser, you don't need significant time off work. You can drive afterwards, and there's very rarely any restrictions on your physical activity. The other thing that's very important to discuss is the use of the eye drops in the post-operative period. Sometimes we stop the glaucoma drops that you're on, or we stop some of them, and we give you other post-operative drops that are specific to the operation that you're having. So on to billing and finances, which I touched on a little earlier. These are very, very general comments just to sort of help put you in the picture as to what to expect, but all the specifics must be discussed with whoever's providing the service for you. And my comments also apply mainly just to Australia, in case there are people tuning in from elsewhere. Now, for those of you who are in a health fund, a private health fund, this covers procedures that are performed in hospital only. It doesn't cover lasers that are performed in the rooms, just the way it doesn't cover your appointments in the rooms. Now, there is a Medicare rebate for all procedures that have a Medicare item number, which includes the lasers that I've discussed and the operations that I've discussed. To receive the Medicare rebate, you require valid referral from your GP or optometrist. You can get referrals from other specialists, but be aware that if you do, that only lasts for 3 months, and it's always a good practice to have a valid referral from your GP or optometrist. Billing and finances can be complicated, so it's important to discuss this with the practice, but you are entitled to know ahead of time what the cost will be for the procedure before you have it. And as I mentioned, you will be required to sign. So for laser in the rooms, there's just usually one single fee, which is the doctor's fee, and there will be a Medicare rebate that you will get towards the cost of that fee. Bear in mind that this isn't necessarily all money that's just going to the doctor, because the doctor is likely to have to pay the practice for use of their facilities, which includes the use of the laser. So these lasers are quite expensive equipment that are expensive to purchase, and also they must be serviced and maintained. And so that's sort of built into the doctor's fee as well. Surgery, and initially I'm going to talk about if you're in a private hospital or a day surgery, there's a number of fees to be aware of. The first one's the surgeon's fee, and there'll be a Medicare rebate as well as a health fund rebate from your health fund. There may well be an assistant surgeon fee as well. Most of the glaucoma procedures do have a rebate for an assistant surgeon if there is one. Some of us operate just on our own, some of us operate with assistants. The surgeon's fee is just part of it. There's also a hospital or facility fee. Now, if you're in a health fund, that usually covers the hospital facility fee. But if you're not in a health fund, then there's an additional cost, which is the cost of the hospital accommodation and the use of the theatres. But this may also include the cost of the prosthesis, which is the implant, if there is an implant. And sometimes we use eye bank tissue for some of these procedures. That's usually covered by the health fund. But if you're not, then these are some of the other expenses that could be encountered. You need to know about this ahead of time. And as I mentioned before, there'll be an anaesthetic doctor present, and so they'll have a fee as well, and there'll be a Medicare rebate and a health fund rebate that goes towards the anaesthetic fee. Now, if you go for surgery in a public hospital, this is generally free of charge, but the trade-off is that there are waiting lists, and so there can be waiting lists and you may not be given a date for your surgery, or you'll be told you're on a waiting list and then given a date closer to the time. The other thing is there's no choice of doctor, which means that you may not be sure who's going to be performing your surgery until you're given a date for surgery. And the other thing that I should point out is this: in many of our bigger teaching hospitals, it usually means that the surgery will be done by one of our trainees. And just to finish off, when we're talking about Medicare rebates, this is there's a designated aftercare period that's determined by Medicare. For most lasers, it's 1 week. For trabeculectomy and similar surgeries, it's 2 weeks. For cataract surgery or tube shunt surgery, it's 3 weeks. And so what that means is there's generally no charge for the appointments that are occurring within this period, but after that period, normal billing can apply. And what this is for is basically if there's unforeseen complications and that you need to be seen multiple times in the first few weeks, that's generally covered by the cost of your surgery. But then after that, for the ongoing follow-ups, it's more routine standard care. And these are relatively artificial, but they're just endpoints that are imposed by Medicare. The reality is that with glaucoma care, it's an ongoing relationship with your specialist, and that goes on for many years. And that sometimes with glaucoma surgery, even though the immediate postoperative period's out of the way, there are ongoing checkups required on an ongoing basis when you've had these surgeries, and there's ongoing follow-up required as part of the glaucoma management anyway. And finally, I'd just like to refer you to our website at Glaucoma Australia. There's very useful information there, including very specific information about some of these procedures. And there's fact sheets that can be downloaded. So I'll refer you to that as well. So I've got some questions coming through now, and we'll go through some of these. I've got quite a few to get through, and we'll see how much I'll try and get through as many of these in the time as I can. The first question from Satish: does the choice of laser or surgery depend on the suggestion of the specialist, or do we have a choice? Well, the answer is both. So I talked about the consent form, and it's not just you shouldn't just have a form put in and you just sign the form. In reality, that's what happens. It's an opportunity for discuss where you're going with your treatment. So the surgeon will offer you the surgery, explain what's involved and why they think it's appropriate, and it's a discussion with them. So in reality, patients are very guided by what their specialist will suggest, but it is up to the patient if they want to proceed or not, and it is up to the patient if they're happy with that, and you're always entitled to ask about what the alternatives are. Okay, but certain specialists will have preferences for certain techniques, or they'll have reasons why they're recommending a certain procedure in that situation. So it's important to discuss that and make sure that you're both happy with the plan before you proceed with any intervention. Okay, question from Grateful Macca. What are the postoperative manipulations? So with that, I was talking mainly about trabeculectomy. Trabeculectomy, we make a little hole in the eye to drain fluid into what we call the subconjunctival space. And we can make that hole to drain the fluid, but your body may try and heal that up. And that's the main thing that we worry about, why it may be unsuccessful. So in the postoperative period, if we think there's signs of excessive scarring or healing, we can inject anti-scarring agents. We can adjust sutures so that the bleb is draining more. We often put more sutures in than we need to avoid a low pressure in the postoperative period, and then we remove some of those sutures later on if we need more drainage. So there's for those sorts of operations, it's kind of like the operations half of it, and the other half is the aftercare, and that's a period of 6 to 8 weeks. So that's worth knowing about before you go into it. But that's not all glaucoma surgeries. When I mentioned the so-called MIGS or microinvasive surgeries, they tend to be less invasive and less postoperative care required, but nevertheless, you still will have postoperative appointments. The pressures can go up and down and fluctuate, and we may need to change the drops that you're on and keep an eye on that as that progresses. So it depends what procedure you're having, but with all of them, there'll be certain things that need to be checked afterwards. It's not you just do it and that's finished sort of thing. Okay, I've got another question from Tony. How do you determine what procedure is best for you, laser or surgery? Look, that depends very much on what the stages of the glaucoma. SLT is done for milder forms of glaucoma, whereas surgery is done for more advanced glaucoma. That's the main thing, but there'll be individual cases will vary, and it will depend exactly on your situation. Okay. What is okay? Look, there's a question about risks with laser and surgery, and what are the risks and what is the success rate. So, look, that depends what surgery you're talking about, and depends what laser you're talking about. In general, the lasers are less risky. It's a less invasive procedure, and the surgery tends to be a more involved thing. The lasers tends to be used for milder cases, whereas the surgery is done for more advanced cases. The specific risk will vary depending on what procedure you're having. And so, if you've been recommended a procedure, it would be good to find out as much as possible with that particular procedure and then discuss it in detail with your surgeon so you know what you're getting involved with ahead of time. All right. Now, we've got some other questions in, but I'm just having a little bit of trouble seeing some of the earlier questions. Maybe if we can send some of the first ones again. Okay. Does laser treatment hurt? Okay. So, generally not, but you feel it. You won't need to take serious painkillers or anything like that. The laser PI is different to the SLT. If you recall that slide I showed, with the laser PI, we're actually putting a hole in the iris. I explain it to people, it's a bit like being flicked with a rubber band. You'll feel a little flick, and I like to warn people ahead of time so they don't sort of snap their head back when it happens, but it's not a severe pain. You feel it, and then it might take a few shots to get through. The doctor's talking to you as they're doing it because you're actually quite close to each other while they're doing it. So you know what's going on. SLT is, you can gently feel a little bit of treatment as it's going in, but it's generally not painful. Okay. Will both eyes be done at the same time with laser? I tend not to. Some of my colleagues may do so, but generally not. It depends what particular laser is and why it is and what the time constraints or other issues might be. As a general rule, I tend to do one eye at a time and let that settle down. And then the patient also feels a bit more comfortable as to what's involved with the second eye. But there may be certain situations, if things are very emergent, there's a bit of an emergency, or if things are urgent, where you may want to do both at the same time. SLT, just in general terms, it's got about a 70% success rate as an initial procedure. So I do one eye first. I tend to do one eye first, make sure there's been a favorable response before recommending it for the second eye. Yeah, yeah. I've got a question for Robin about PI. I mean, look, I don't want to. I don't know if I can comment so specifically on things, but I did just sort of describe what tends to happen with PI. There is a point where the laser goes through the iris to make a hole, and if patients aren't expecting it, they can sort of put their head back because it's like a sudden sort of flick. Um, and look, that doesn't cause a problem. It's not ideal if you move your head back, but nothing bad's gonna happen from that. The laser happens instantaneously when it goes. Um, when it goes. With laser iridotomy, just because we're asking about pain and that sort of thing, with laser iridotomy, there will be a little bit of inflammation in the eye, which is normal because we've made the hole in the iris, and we tend to treat with topical anti-inflammatories, and that will settle it all down. So some irises are thicker. The tissue's thicker and it's harder to get through the tissue, so you need more shots or you need higher power shots, and in which case there's more likely to be inflammation afterwards. And so we usually treat that with anti-inflammatory, and the results will vary for different individuals. But that's why we often check you straight away afterwards, and then we'll get you back for a follow-up appointment to see how that's going. And that can all be managed and treated depending on how things go. Okay. So I've got a question. Is it worth taking painkillers before a laser treatment for glaucoma? I've never recommended that. It's uncommon that things are so bad after the laser that you need to take those painkillers, and if that is the case, there'll usually be a reason why. I find topical anti-inflammatory drops is the best way of settling down any symptoms. It's not the sort of thing that you should be taking strong painkillers for necessarily, but if there is an issue with your condition, then your doctor can assess that and make recommendations about that. Okay. Um, how many days should I take off work after glaucoma surgery? So this depends what procedure it is. It also depends what type of work you do. If it's an office-based work, then you won't need to take as much time off as a physically demanding job. But I think it's important to discuss that ahead of time. It depends if it's a trabeculectomy or external filtering surgery, the eye's going to be uncomfortable. And for office type work, I say usually 1 to 2 weeks. And if it's a really physically demanding job, it could even be 4 to 6 weeks. It just depends on the nature of the work that you do. For other glaucoma procedures that perhaps aren't as invasive, then it may be more like cataract surgery, where again, we'd say maybe a week or so. This is very general terms, a week or so for an office type job, and possibly 2 weeks for a more physically demanding job. Sometimes I ask people, is there light duties you can do? And then we sort of look at giving you time off work, giving you a medical certificate and that sort of thing. It could be longer. I mentioned about the post-operative manipulations and things with surgeries like trabeculectomy. For example, if your pressure is very low, we might extend that period and say it's really important you don't do any bending or heavy lifting. And if your job involves that, then you might need a more prolonged period off work. And the vision might be blurry and take some time to settle down after the operation as well. Okay. I've got a question from Andy. Does glaucoma surgery alter the glasses prescription? Yes. So it may do. It is a good idea to wait until things have completely settled after your glaucoma surgery before reviewing that. Um, it depends again what this particular surgery is, but if it's something like trabeculectomy or glaucoma drainage tube, the so-called traditional glaucoma surgeries, there may be subtle changes, not major changes. If it is something that is associated with cataract surgery, and I mentioned some of the angle surgery or the MIG surgery are associated with cataract surgery, then that will definitely alter your glasses prescription, because when we're doing cataract surgery, we're changing the lens of the eye. Some people's glaucoma may have a narrow angle component. So when we do the cataract surgery, we're taking the lens out and putting an artificial lens that actually opens up the drainage angle. And so that may be recommended as well as for improving the vision, but also for improving the angle anatomy for the glaucoma. So there is a chance that it could significantly change your glasses, but maybe with some of the other procedures more subtly. Okay, we've got another question. Is recovery from glaucoma surgery similar to cataracts? I think I've sort of answered that a little bit when I was talking about the time off work. It is similar, but some of the glaucoma external drainage procedures do take longer to recover from, and there can be a longer post-operative period. Cataract surgery tends to recover more quickly. With the glaucoma surgery, we often have sutures on the outside of the eye, which you feel, so there'll be a little bit more irritation associated with that. And the follow-ups, where with cataract surgery, we tend to just check things and make sure everything's all right, whereas with glaucoma surgery, we may need to perform manipulations. Got a question on transport before and after surgery. I think that's important. Definitely, because of the sedation and the anesthetic, even if it's under local, you need someone to take you into the hospital, and you need someone to take you home. You'll need someone to take you back the next day at the post-operative visit. And it may be that you recommended that you can't drive for a week or so afterwards. It will depend on the vision in the other eye. The eye that you've had the surgery in may be blurry for a period. It can be blurry for up to a few weeks sometimes. It's very variable. We've got another question. on transport as well. Is there any form of community transport that assists? So again, this will depend where exactly you are. So I'm practicing in Sydney, and there is community transport. It's based on where you live in your locality, and you should make inquiries about this beforehand. And it's a very useful resource, especially for people who don't have friends or relatives that can provide transport for them. And you need to get that looked into before and discuss any concerns you have about that with your surgeon before you have the surgery. I've got another question that's sort of related to this about someone living on their own and don't have anyone to help. So, so community transport's one thing that we've covered. You have to put in eye drops after the operation yourself. Now, with patients with glaucoma, you would presumably be doing those eye drops for your glaucoma anyway, so it shouldn't be that different. The main issue will be the transport issue and coming for the post-operative appointments. I've got a number of patients, often if they're elderly, that live on their own. They've had relatives stay with them for a little while, if they've been fortunate to have relatives or grandchildren even that can take them to appointments and that sort of thing. And it's just a case of working out with your family or with your surgeon as well, like what's the best way you can handle things in the post-operative period. They'll give you an idea of how many appointments are likely to be required over what time course. But you're not bedridden or anything like that. You know, comparing this to other surgeries like major abdominal surgery or something like that. So, you can still do things in your own home. It's just the usual restriction is sort of the strenuous activity. Um, okay, so I think we've got time for one more question. We've got a question for Sue. Is SLT success and risk dependent on the skill of the ophthalmologist? So I think one of the nice things about SLT is it's a fairly standardized procedure. The laser gives we do titrate the energy with the laser, but it's a fairly standard procedure. Most of us perform it the same way. People may have different preferences in terms of how much of the angle they treat, but the reality, I think it's a fairly standard procedure as opposed to some of the other ones. So I think SLT's fairly standard, and in terms of the competency, I think all general ophthalmologists, when they've finished their training, it's well within their levels of competence to perform SLT safely and effectively. So I think, as I mentioned, we quote success rate up to 70%. I mean, I think if the SLT doesn't work, it's not so much down to the skill of the individual person, but just that for reasons that we don't fully understand, some people respond better than others. I mean, some of these reasons we do understand. It's a bit complicated to go into, but it may not be the trabecular meshwork where the obstruction is to the aqueous outflow. And the other issue is that some patients, we want to get a really low pressure, and it's not that the SLT doesn't work, it's just that it may not get the pressure down to where we want it. So some of these other procedures I've mentioned are fairly specialized, and so that's why there's less of us that do it. But SLT is a fairly standard procedure, and there's not a lot of variation between practitioners. So look, I thank you all for your questions, and I hope this information was helpful. And I do have to wrap the session up now, but I am more than happy to give further answers to any questions that you want to email to Glaucoma Australia. Our educators are happy to answer the questions that you have, and it can be passed on to myself and my colleagues who are on the clinical committee and are happy to help where we can. So thank you very much for your attention, and good luck with your ongoing treatment for glaucoma. And I hope that what I've said has helped provide some answers to questions you might have or that you were wondering about. And so things might be a little bit less confusing as you go forward. All the best now, and good night.